Good morning, good afternoon, and good evening to our global audience. We're pleased to have you joining the Leading Health Systems Network in our continued discussion on antimicrobial stewardship. My name is Mary Helen Pombo, and as a fellow at the Center for Health Policy at Imperial College London and lead on the Leading Health Systems Network program, I'm delighted to welcome you to this webinar titled Antimicrobial Stewardship at Scale in Southern Africa, Beyond a Low-Hanging Fruit Model. To give you some context about the network, the LHSN is a collaborative international network of healthcare leaders and organizations working to improve health service delivery. Based here at Imperial College, LHSN works in partnership with the World Innovation Summit for Health. As those following our network may have seen, this year LHSN made a call for webinar proposals on innovation in antimicrobial stewardship, which brings us today to host this selected spotlight webinar dedicated to providing a regional example to two questions on the minds of many. How do we provide improved quality and safety in healthcare services efficiently, effectively, and at scale with limited resources, such as limited infectious disease expertise, as is the case in settings in Southern Africa and various other settings represented by our audience today? And secondly, how can we better leverage technology to address this challenge? Now, just before I move on to speaker introductions, I'll briefly note that we are on social media and invite you to join today's conversation online via LinkedIn and Twitter. Our hashtag and handle for this event are available on the presentation. After our presentation, we will allow time for questions and answers, so we welcome you to send over questions during the presentation, and we will add them to the queue. With that, I will introduce our three outstanding speakers. The lineup of our speakers is as follows. Ms. Angelique Messina is Quality Systems and Innovation Manager of Antimicrobial Stewardship at Netcare Hospitals in Cape Town, South Africa. In this role, Ms. Messina leads the management and implementation of the antibiotic stewardship program across 56 Netcare hospitals in South Africa. She is a working group member of the South African Antibiotic Stewardship Program, and in 2017 she was appointed honorary lecturer at the University of the Witwatersrand's Faculty of Health Sciences. She obtained a bachelor's and master's in pharmacy. Following the first presenter is Dr. Daryl Vine, who comes to us as medical director at Bluebird in Cape Town, South Africa. As a Canadian and South African OBGYN and member of the Royal College of Surgeons of Canada, since 2011, Daryl has been dedicating himself to finding solutions to antimicrobial resistance in medical facilities. Those efforts resulted in Bluebird, a standardized, cloud-based integrated infection control and antimicrobial stewardship system, now used in more than 70 large hospitals and more than 150 intensive care units. Dr. Vine is quite active on Twitter, so feel free to follow his tweets on infection control and stewardship at EasyASP. The presentation will close with remarks from Ms. Sonia Coleman. Ms. Coleman is a clinical pharmacist at the Nelson Mandela Children's Hospital, a new pediatric hospital in Johannesburg, South Africa. She started her AMS career at Netcare in 2011, and now at Nelson Mandela Children's Hospital, she is responsible for the AMS program implementation and is chairperson of the AMS committee. Ms. Coleman is also a member of the Gauteng Provincial Antimicrobial Stewardship Committee and is National Vice Chairperson of the South African Society of Clinical Pharmacy. She obtained a bachelor's in pharmacy from Wits University and an MSc Med in Clinical Pharmacy from Medusa University. Angelique, Daryl, and Sonia, we're delighted to be drawing on your expertise today. So now, without further ado, I'll turn it over to our first speaker, Angelique, who will start off this presentation. Thank you so much for joining us, Angelique.
Thank you so much for the introduction, Mary, and we're delighted to share in this webinar with all our colleagues around the globe today. Just to give you a brief introduction regarding our hospital network, which is the Netcare Hospital Group. We're a network of 56 private healthcare facilities across South Africa. Collectively, we have over 10,000 registered hospital beds. Our footprint across South Africa can be seen in the graphic, and you can see that it spans across multiple provinces within the country as well. And the range of hospital sizes is from small clinics to large quaternary referral hospitals as well. If we move on to the next slide. As Netcare, we recognized that there was an opportunity for stewardship, being one of the largest healthcare providers in South Africa. And we recognized that any work that we did in antibiotic stewardship within our hospital network would have a greater impact on South Africa's antibiotic resistance problems as a whole. So we undertook a journey to set up an antibiotic stewardship program across our hospital network using existing resources. So our system consists of non-specialized infectious disease trained pharmacists, so we generalist trained pharmacists. Private practitioners, our doctors, consult their services to our facilities and are not employed within the network. We also currently on a paper-based prescription chart and admission nursing documentation is all paper-based. We do not at the moment have an electronic healthcare record system. We also operate in the context of multiple private laboratories, so there's about 5 or 6 major laboratory systems that doctors can select services from. And we also have limited infectious disease trained physicians across the country. So across the private and public healthcare sector, there's less than about 50 of these infectious disease trained physicians. So utilizing this system, we recognize that we can't sit back and do nothing. And so we thought, what happens if we actually take what we currently have and create a simple framework of low-hanging fruit interventions that our generalist pharmacists can review either at the bedside or within the pharmacy when they are looking at prescription charts for antibiotic prescriptions. So our journey initially started in 2011, and we worked with about 64 pharmacists over a 5-year period, defining 5 low-hanging fruit interventions, which looked at ensuring a culture was done prior to the initiation of treatment, monitoring duration of antibiotic therapy, including 7 days and 14 days, looking at inappropriate duplicate spectrum of activity for antibiotics prescribed, and looking at patients that were receiving more than 4 antibiotics at the same time. Our journey over the 5 years required a stewardship intervention to take place, almost 1 in every 15 prescriptions reviewed. It took 53 learning cycles, those were either face-to-face or telephonically over the years, to help support and guide the stewardship program across the country. We also mandated protected pharmacist time for stewardship ward rounds, and initially this started out with 1 hour a day for pharmacists to go primarily to the ICU to review prescription charts. It required leadership endorsement at all levels throughout the organization, the provision of guidelines, data collection tools, definitions, and a stringent framework with which the pharmacist could then operate within. Extensive training of all the pharmacists to understand the bundle of interventions and how to actually implement them. Submission of data monthly to the project manager, which in this scenario was myself. And this really helps in terms of garnering the necessary movement of the antibiotic stewardship program, because there was someone at the end of every month waiting for data to be submitted. Intensive support, the provision of coaching and encouragement to frontline pharmacists doing this work was also necessary. And then feedback was individualized based on the particular pharmacist and the particular hospital setting that they were working within, to help move forward and ensure consistency and support and encouragement with their stewardship work going forward in that hospital. The results was our initial publication in the Lancet Infectious Diseases, where we managed to decrease our antibiotic consumption using the DDD per 100 bed day methodology by around 18% using this low-hanging fruit pharmacist-driven initiative. If we move on to the next slide, we had to adapt our model to suit our local setting. Many international in resource-rich countries use ID specialist-trained either physicians or pharmacists to lead their stewardship programs. Over here, we had to use our generalist pharmacists as the main driver, however, recognizing that they weren't able to do this work in isolation and needed the collaboration of the multidisciplinary healthcare team in order to drive this work in each individual hospital. We also had the additional resource as the overall stewardship project manager in order to guide, support, and coordinate the implementation of the program across the hospital network. So moving on to the next slide. We used the Breakthrough Series methodology, which is we adapted from the Institute of Healthcare Improvements. And I'm not going to go into the details of this methodology because there is a white paper available on the website using the link on that slide. But really what the Breakthrough Series Collaborative does is that it gets everyone into various learning sessions. And like I said, we use 53 of these kinds of learning sessions in our initial journey. But it also requires intensive support. So someone that's there to follow up, make sure everyone's on track, provides the necessary feedback, helps troubleshoot when systems break down, etc. And really helps support the journey as it progresses. But what the great thing about the Breakthrough Series Collaborative does is it really helps to accelerate spread and impact across multiple facilities. And what I love particularly about the Breakthrough Series is that it really stretches the boundaries of what's possible, because someone can be sitting in a room thinking that these ideas are completely impossible and it's so challenging to implement in a particular hospital, but there'll be someone else in that same room that's there that says, oh, but I was able to overcome this particular challenge by doing A, B, and C. It also helps for participants in the learning sessions to learn from each other so that they can make a bigger impact faster. And you can collectively identify common challenges and ways in which to overcome them in these learning sessions, because participants really help support, motivate, and encourage each other to succeed. So if we move on to the next slide, we came to a point in our stewardship journey that we really started to consider how can we overcome the paper-based limitations of our existing stewardship initiative. And in around the year 2014, we started exploring how this can be done, because we had really asked ourselves, how do we take our antibiotic stewardship program to the next level of excellence in our organization with the aim of ensuring appropriate antibiotic use for every single patient in all of our hospitals. So we then started exploring various systems, and we came across the Bluebird system. And one of our biggest challenges was the disjoint and disconnect between the laboratory data. These were paper-based reports that were slipped into patients' files initially, and we had to sift through a whole lot of paper to try and find the laboratory results. Sometimes they were missing in the patient's file, or they were filed incorrectly. If doctors were using two different laboratories, we had to look for results from one laboratory in one way and another laboratory in another way. So what was required was an integration of our laboratory data on one cohesive platform so that we could review antibiotic therapy against any laboratory data in a seamless manner. So the Bluebird system consists of both an antibiotic stewardship module and an infection control module. But for the purposes of this presentation, I'll be focusing on the antibiotic stewardship module. How the system works on a very high level, Daryl will go into the detail later on, is that it integrates laboratory data from the multiple private laboratories available. It takes our medication dispensing data as well as our patient electronic master admission file and integrates those and adds some intelligence to it. That then provides us with a web-based electronic surveillance system that then also customizes particular alerts and work list items based on rules that we have implemented, of which the pharmacist can then take their mobile devices and go and do their bedside surveillance and implement the necessary recommendations or interventions that they require based on their review. So if we move on to the next slide. We already, as I've described, had an existing antibiotic stewardship program that really looked at the utilization of Excel spreadsheets to document our interventions. So when we transitioned onto the Bluebird system, it really helped us, helped our stewardship review in many ways. Initially, it was really difficult to find which patients to look at in a ward. So the Bluebird work list, based on a set of target antibiotics identified, immediately alerted us to the necessary patients we needed to go and see in a ward, instead of going bed to bed to bed to bed to go and identify which patients were even on antibiotic therapy. It forced us to cover the whole hospital, where particularly we may have just been doing 1 or 2 wards. It gave us data across the whole hospital. Like I've mentioned, it provided an integrated platform for our laboratory results, as well as a platform to capture all of our stewardship interventions that we were previously doing on an Excel spreadsheet. As a consequence of this, it gave us real-time reporting, which we could then use to help drive some quality improvement initiatives in the hospitals based on the data available. We were also able to customize alerts to alert us to important information requiring our attention for particular patients, for example, drug-bug mismatches, antibiotic toxicities relating to renal function, inappropriate durations, etc. The system itself helped formalize an initial review and a day 3 timeout audit on antimicrobial therapy. So it gave us a standardized way of reviewing each patient when they were prescribed antibiotics. And it really helped to deliver a more efficient, consistent, and standardized stewardship review for all the patients within the hospital. So if we move on to the next slide, we initially piloted the system in 4 hospitals over a 10-month period. And again, we used improvement methodology to do this in the sense of real-world testing. So initially, we got a module from Bluebird that we then tested and modified, and based on the end user feedback received, we then made additional system modifications, going back and forth like this over a 10-month period. So we were able to implement rapid cycles of change based on the feedback received, and within those pilot hospitals, we had weekly feedback sessions with the end users, so that we could quickly sort of fix and address any problems that did arise. After the implementation of the pilot, we then rolled out the system over an 18-month period in clusters of hospitals. So they were hospitals were clustered based on geographic area, not more than 5 hospitals per cluster, and we rolled out the ABS and infection control modules at the same time. The process for rollout was that there would be a 1-month pre-rollout onboarding session, which required hospital preparation and leadership endorsement. The 2nd month would be dedicated to training and hand-holding, and in the 3rd month, the hospital would go live on the system. So if we move on to the next slide, this slide just details further the implementation methodology that we used. And the onboarding session really looked at the hospital infrastructure required and a sign-off of resources that were necessary. So we had to procure additional mobile devices in the form of iPads, ensure that the hospital Wi-Fi was working efficiently, that there was enough IT support locally to help support any IT infrastructure challenges on site, and that we had sufficient resources in place in order to execute this work. Then the training and hand-holding that took place in month 2. The Netcare itself did the training of the Bluebird system in our organization, and so we had a Bluebird Netcare Bluebird training team that consisted of myself for the pharmacy module, Ms. Karen Swart for the infection control module, and Mr. Dave Rieger was the overall project manager across the network. So we conducted the training with our teams, and following the training, then access was granted to the system in week 1. In week 2, participants were then sent back into their facilities to test the system and use the system in their everyday practice, and we would be there to troubleshoot and support as needed. Then in weeks 3 and 4, we would be on site providing intensive support and just making sure that all the users were using the system appropriately and establishing the right methodology for system utilization. And then finally, we would go back into the hospital in week 4 and sign off each user's assessment and make sure that the system was utilized appropriately. So our rollout took 18 months of a period of 2015 and 2016, and we rolled out all 56 hospitals during this time. We trained various end users. We trained both pharmacists and pharmacy managers, infection control nurses and nurse managers, ward secretaries that helped with patient allocations, as well as unit managers, so that they could really understand the infection risks associated with their units as well. If we move on to the next slide. Comparing our world pre-Bluebird and post-Bluebird, obviously our data collection now is electronic. We have monitoring across all our wards in the hospital. We definitely required more pharmacists in order to do this work, so an additional sort of group of pharmacists were taken under the low-hanging fruit training methodology before access to the system was granted. Our run charts and our data were all generated automatically that we could then utilize for improvement work at the front line of care. The system also prompted us to do standardized interventions, whereas previously we were doing sporadic interventions when we thought were necessary. It formalized an initial day 1, day 3 review according to obviously international best practices. We were required to manually look for through the patient's file for all the information, and with the Bluebird system it was then integrated for us to look through, including culture sensitivity results and other laboratory markers as well. And in addition, the Bluebird system gave us an opportunity to remotely have a broad oversight and supervisory role across all hospitals in real time as well. So if we move on, there's a whole bunch of data that we can use to show the results of the implementation of the system, but for me personally, I think the value of the system has been in the number of patients that we are seeing on a monthly basis, which has grown substantially as our proficiency and the utilization of the system has increased. And I think that's really what you want. You want to be able to ensure an appropriate stewardship review, at least using sort of international best practice criteria to review therapy to the most number of patients that you can possibly. Also with that, our number of stewardship interventions has increased, including obviously because we have better recognition of inappropriate therapy faster. So we look at an average of about 96% of alerts closed every month, and at the moment our network is sitting at around 78% average compliance of the work list completed, which is quite remarkable based on the volume of data received. In addition, in terms of outcomes, at a group level, we decreased our antibiotic consumption during this period by a further 1.2%. Knowing that this is a hospital, sort of 56 hospitals grouped together, there were some hospitals that were able to show a further decrease in consumption, and then some hospitals that weren't able to do that. So this averages out to about 1.2% decrease. If we move over to the next slide, just thought it would be appropriate to share some of our lessons learned. This concept of alert fatigue is really real. The thing about implementing an electronic system is that you get a whole bunch of data coming at you that doesn't disappear unless you work on it. So it was really different from doing our paper-based round For instance, if we weren't able to do a round one day, we would just pick up the next day. But with the electronic system, the data is still there, and you have to address the previous day and the current day's work at the same time. So it really was a paradigm shift in our learning and the way in which we dealt with it. The IT and connectivity challenges needed to be overcome, and this sometimes did impact the user acceptance of the system. I've spoken about dealing with the volume of data, which was initially a challenge, and that is why we also required additional resources in terms of pharmacists that were initially anticipated to be trained in order to meet the necessary workload demands. Balancing the pharmacy operations and clinical ward rounds initially was also a challenge, because it was the first time that we had done this in South Africa, and ensuring pharmacists were outside of this dispensary to do these antibiotic stewardship patient care rounds. It still required the normal operations and drug delivery services of the pharmacy to continue. And so balancing that was really challenging, and our pharmacy managers were really integral in helping us get that right. Initially, it required us additional time of our end users so that we could ensure that we were using the system properly. Also, a true distinction between managing the system, this concept of chasing the numbers, rather than using the system for appropriate stewardship review, was something that we have had to address on an ongoing basis, because it's easy when you have an electronic system to meet the necessary targets, but it's a very different thing to meet the necessary targets and do appropriate stewardship. And then ongoing, looking into how do we further optimize the system to minimize manual data collection as far as possible. If we move on to my last slide, I think in conclusion, having the data available to review in real time is critical to the prospective audit and intervention feedback strategy that we utilize for our antibiotic stewardship program. Pharmacists really feel empowered with the necessary information at the point of care, and it really did help to enhance relationships with prescribers because you had the accurate, up-to-date data available when it was needed. And I think that's been the most powerful tool that the system has brought us. And definitely the implementation of the system has really helped to ensure program sustainability for all patients at all times in any of our hospitals. So I'd just like to acknowledge the team that was involved in all of this work, and I have included my Twitter handle if you guys have any questions. So thank you very much. I'll now hand over to Dr. Vine to continue.
Thanks very much for that, Angeliki, and I really appreciate us being invited to share what we've accomplished over the last 6 years. So I'm going to race through this very quickly, just so we can give Sonia a bit of time to cap off. What is Bluebird? Bluebird's a cloud-based organizational framework that's designed to institutionalize AMS across a whole group of hospitals. And the cloud-based is important because that enables it to minimize hospital IT resources, which are generally scarce across most global hospitals. When we first designed Bluebird, now going on about a decade ago, we were very careful to use CDC guidelines. And later on in our journey, we came across the excellent work that's been done in Australia. And so we also incorporated the Australian Commission on Safety and Quality in Healthcare. If you want more detail about Bluebird, there's a link at the bottom here to a brochure. It's intelms.com/22. I'm not going to go into the nuts and bolts of it in much more detail than that. We really have been lucky enough to stand on the generosity of the shoulders of giants. I'm not going to go through everybody on this slide, let alone all the other people that have helped us, but there's some core things that I'll touch on as we go. So firstly, Angeliki and Dr. Dina van der Berg's groundbreaking work on low-hanging fruits and decreasing the DDDs has been well described in the Lancet and others, and they really provided a foundation to the Bluebird Stewardship Program. Debbie Goff, who's familiar to most of you, has been intimately involved with Netcare and Southern African Stewardship for the last at least 6 or 7 years that I know of, and has been a very valuable resource to me personally. I'm not going to list through the others. Suffice it to say that the people with asterisks, those blue asterisks on the left, all have great online resources, and they're really worth looking at, and it keeps us able to keep Bluebird up to date almost in real time. Bluebird is multidisciplinary. It's really the glue that ties the team together. An integrated infection control and AMS solution is essential, I believe, and I think that that's been really well explained by Trish Pearl, and the URL to her talk is at the bottom of the screen. Bluebird, as Angelique's pointed out, also allows many other team members access to patient information and to work lists and workflows. I just quickly want to say something about infection control. Perhaps the best way of decreasing antibiotic use is to make sure that that first spark of an infection in a healthcare facility is contained. Peter Collignan's made this point in The Lancet recently and on Twitter. So one of the really outstanding tools that we stole courtesy of Joe Talon at Westmead in Sydney was this real-time view of at-risk patients or patients with multi-drug resistant isolates. So what happens here is management, so for instance the hospital manager can log on and in real time can see where all these patients are in the hospital, and most importantly what's been done to contain spread of that and the contagion around the hospital. So if, for instance, in this case, infection control hasn't seen patients yet and certainly hasn't implemented any infection control precautions, that hospital manager can get on the phone and speak to them. And at a unit level, the unit manager can do the same thing for their unit. As Angelique has explained, Bluebird was designed to try and lighten the load to make everything available in one interface or within one click away from that interface. We try to standardize the clinical workflow to operationalize the system across 50 hospitals, and in doing so to try and maximize efficiency. So the overview of how we did this is we received data from legacy systems, from hospital location systems, admission, discharge, transfer, from labs, and we got all the labs, not just micro, and all the dispensing information. And we're also capable of getting things like surgical feeds and device feeds from EMRs. And if the hospital isn't capable of producing any of those feeds, all of this can be manually entered into Bluebird. So we get a wealth of data. We apply intelligence to that data, algorithms that have been developed over the last decade. And that does many things, including raise alerts, but in particular, we try and identify the patient at risk who will benefit most from professional expertise, infection control, or stewards. We send them to that patient's bedside and try and provide clinical decision support. And in that whole process is monitored and metrics are available for management to dissect. I'm just going to touch on a few high points. This one is something that we were lucky enough to be given by Debbie Goff. So I went and spent some time with her in Columbus. She has done great work on staph bacteremia. So we took that back to South Africa and we extended it to other organisms. The one I'm showing you here is candidemia. And I just want to show you an example of what we do with alerts. So the alerts are shown on the left pane, and any alert that's highlighted gives a right pane working space. And besides giving all the details about the alert, to close that alert, one has to show what one actually did to manage that problem. So in this case, because we get all this information, we know that this patient's got a central venous line in, and we can prompt the pharmacist to suggest that maybe a source control intervention, in this case removal of the central venous line, might be a good idea. We also know that the patient's on fluconazole, so we can prompt an escalation intervention to maybe think about adding or changing the antimicrobial to echinocandin. Candidemia can seed out in the eyes, so metastatic intervention to ask for an ophthalmologist to see the patient and see if anything's seeding out in the eyes, and so on. So you can't actually close the alerts until you say what you've done, and in many cases it just might be that the treatment's appropriate. So one can do this relatively fast, but for alerts like this with a high mortality, one can lead a sort of consistent standard of care across all the hospitals. We also had to find an intuitive interface that's cut the learning curve. As you can see initially, the really great work that Angeliki and her team did, but it required a lot of resource-intensive training. So one of the things that we've really tried to move towards is virtualizing all the units in the hospital. So in this slide, one walks into the trauma ICU. All the patients that are in that ICU are listed, and very quickly one can get a lot of information about any particular patient. So if one looks at the first line here, one can see that I won't go into the detail of how I know this, but I know that this patient's got at least one multi-drug resistant isolate. They've got a urinary catheter, and this Foley's been in for 46 days, and no audit's been done yet today to say why the catheter is still necessary. This patient's on antimicrobials and needs an audit, and the audit hasn't yet been done today. But more importantly, logged in here as a member of the Antimicrobial Stewardship team, I can see that these 3 patients with the highlight here on the left margin in red need to be seen by the Antimicrobial Stewardship team based on the rules that have been set up in conjunction with supervisors such as Angeliki and her team. Each of these patients has a work list. If one clicks the work list, one gets a pop-up explaining why those patients are on the work list and the ability to deal with that issue. And as soon as it's dealt with, it's grayed out on the work list. And once all the items are grayed out, the patient disappears off the work list and this marker disappears here as well. So it's a way of making sure that a certain standard of work gets done across all wards in the hospital and in a group of hospitals across all the hospitals. One can, of course, go and do ad hoc interventions as well, but this is a basis for organizing all of this across an institution. I'm not going to spend much time on this, but if one clicks on the antibiotic icon, one gets a whole lot of stewardship tools, and all these tabs are different tools. I've selected the drug bug tab. What this does is shows all the isolates that have come in on this patient during this admission, including all the lab sensitivities that have been reported by whatever lab they went to, and the antimicrobials that this patient's been put on during this admission. And you can immediately see that this patient's on some broad spectrum antibiotics, including pip/TAZ for 26 days. And they did this because none of them cover all these isolates. But very quickly, you can see that Genta, for example, would have covered all of these. So at the bedside, this becomes a very powerful tool to allow the stewardship team to make interventions that quickly impact patient care. As Angeliki mentioned earlier on the work list, so if this patient needed an audit, it was because the patient was on a target antimicrobial and no audit had been done yet for that day on this new antibiotic. Initially, we made this more complex than I think it needs to be, and I think it's one of the lessons that we've learned. So that great lesson that Dina and Angeliki showed and published by using a small number of interventions and really showing improvements. When I first got involved in this with Netcare, I made the mistake of thinking that we could do everything perfectly and tried to get all of these interventions done at once. And in retrospect, that was a mistake. What we do now is the supervisory module, the one that Angeliki has access to, allows one to, there's a lot of customization that one can do, and the customization is done very easily. One doesn't need any IT expertise. But the example I'm giving here is that one's looking at customizing the audits, and on that initial audit, one can choose one or more items instead of having to have the whole list that the pharmacists then have to go through. So Australians will recognize this next part of the slide, but really Stewardship 101 is making sure that there's a clearly documented indication for therapy, either on the prescribing chart or the EMR or on the patient charts, because you can't know if something's appropriate if you don't know why it was being prescribed. And then secondly, if there is an indication, and for that indication your facility has local guidelines, somebody without a lot of expertise can tell if what's been prescribed is concordant with that guideline. And as long as it either is concordant with that guideline or there's a note in the chart that explains why the physician has decided it's not necessary to stick to the guideline, that would be considered okay. Anything short of that would create an intervention. The remote supervisory capability, while we're here, I'm just going to go through how that works for pharmacy interventions. So there's a lot that one can do remotely. One can look at all of these, all the hospitals in the group, so Netcare's group, 56 hospitals. If one just looks at one can get alerts, and one can look at alerts for the hospitals and the antimicrobials prescribed and tasks that farms have to do in the hospitals. But just for the benefit of this talk, I just wanted to show the recommendations and interventions. So these are all over the last 7 days in real time. One can look at how many opportunities the pharmacist looked at for interventions. So in this case, over the last week, this hospital looked at 430 different opportunities for interventions. Of those 430 opportunities, they made 13 recommendations. 9 of those were accepted by the prescriber. 2 of them were not. The way we do this is after an intervention has been recommended, 24 hours later, that same patient comes back on the pharmacist's work list, and they indicate whether the prescriber accepted the recommendation or had a reason why they disagreed with it. And if they, haven't got back to that patient yet, they marked as open. And of course, during that time, the patient might be discharged. So we also record if they auto-closed by Bluebird. And very quickly, one should see few of these. If at any particular hospital we've seen that many patients have been discharged before the pharmacist gets to review them, that can indicate a problem, and the supervisor can pick up the phone and speak to that pharmacist and try and work out what's going on. One can drill down to any of these hospitals by clicking the hospital link, and then one gets detail about each intervention, what was recommended, what was done, when it was accepted. I'm not going to, because of the purpose of time, go through much more about this right now. Bluebird has a very comprehensive reporting library. At last count, there were about 150 different reports. I'm not going to go into those now, but if you're interested, just the AMS reports are on this link here at the bottom, which is intelms.com/98. Dina and Angeliki really showed me a lot about stepwise change management, and there are tools in Bluebird that help accomplish that. I'm not going to go through that now either. These were various press releases. I'm not going to worry about that at the moment. One of the big challenges I think we've got better at, you can see how much, how well, but with how many resources Netcare used to roll this out across their hospitals. So what we've done recently, in the last 2 or 3 years, is we've got, I think, really outstanding online training courses which require one to be certified before one can go live on the system. And Sonia, who's going to talk next, this is her certificate when she got certified in the second sort of training scheme when she moved to Nelson Mandela Children's Hospital. Right, that's all I'm going to say, and I'm going to move on now to Sonia.
Hi, everybody, and thank you for inviting me to share our story. So the Nelson Mandela Children's Hospital is a 200-bed state-of-the-art specialized tertiary quaternary referral pediatrics facility serving the children of Southern Africa. We opened our doors a year ago, but we only started admitting patients into the Peds ICU and the neonatal ICU in March this year. We have 10 theatres, and once we're fully operational, we'll cater for nephrology, cardiology, oncology, Peds ICU, neonatal ICU, medical and surgical patients. Being a quaternary referral hospital, what that means is we need referrals from tertiary hospitals within the country in Southern Africa, and a lot of those patients are actually arriving on our doorstep with infections, especially multi-drug resistant infections, which are resistant to most antibiotics. So we were very cognizant of the fact that our antimicrobial stewardship practice needed to be world-class and was of paramount importance. Next slide. So coming from where I had vast experience with Bluebird, as well as a lot of our team members at the Nelson Mandela Children's Hospital. So what we liked about Bluebird was that with Bluebird, it enabled us to work smarter. We could target our stewardship activities, resulting in improved time management and optimizing outcomes. As I said, we've only been operational for a couple of weeks, so the benefits we're hoping we'll see with time would be a standard measurement of infection rates, reduced, more appropriate antibiotic use, reducing the cost of the patient care, decreasing inappropriate antibiotic prescribing, automated antibiograms which guided empiric antibiotic therapy, and we're actually seeing with the short period that we've been live, improved multidisciplinary teamwork. Next slide. Thanks. So we felt strongly that the standards that we needed should follow international best practice, especially because we're the Nelson Mandela Children's Hospital and we are preserving Nelson Mandela's legacy. So we liked Bluebird because we cognizant of the fact that they work with the CDC guidelines for both infection control and antimicrobial stewardship, with the CDC's core elements for hospital antimicrobial stewardship programs that are all incorporated into Bluebird. We also liked the prospective audit and feedback principles, and previously I had worked with this and had great success from the hospital that I came from. And so we know it works well in South Africa. We also like that it could generate accurate and comprehensive reporting and graphs, and this has allowed us and will allow us in the future to have multidisciplinary discussions and planning of the projects needed to improve the stewardship and RPC activities at the Nelson Mandela Children's Hospital. And then lastly, the supervisor module was important to us, so it enables the senior managers to monitor what's happening in real time and, if necessary, review and manage the clinicians working in the hospital.
Our sincere thanks, Angelique, Dr. Vine, and Sonia, for your presentations. It's allowed us to explore in depth how the Bluebird system, a cloud-based technology platform for institutionalizing AMS across hospitals, has helped Netcare to improve not only their AMS programs, but also the quality of care that they provide. We've also gained some interesting insight on how Bluebird is expected to do the same at the Nelson Mandela Children's Hospital. As I mentioned prior, the LHSN is based at the Center for Health Policy within the Institute for Global Health Innovations, a strong driver and advocate of innovative solutions to global healthcare challenges. So we're really delighted to have you sharing these experiences with our audience. It seems that you've left us with a very clear overarching message, which is that the Bluebird system has enabled antimicrobial stewardship programs in Southern Africa to overcome paper-based challenges. I think that's the words of Angelique earlier today, challenges such as misfiled lab reports, adapting to differences in laboratory reporting, while also incentivizing decreased antibiotic consumption and adherence to international best practices, and greater levels of monitoring across wards, among other improvements. So we thank you. We thank you again for those presentations. At this point, we can open up the question and answer session. Just as a reminder, you can use the chat function by typing in your questions into what appears as a question box in the control panel, or use the raise hand function to pose live questions. We welcome your questions, comments, and any reflections that you may have along with your name and affiliation. Now, to start us off, we do have a question. In light of the upcoming LHSN webinar on behavioral changes for successful AMS programs, could you comment on how health professionals experienced the change within the AMS program as Bluebird was rolled out, and mention any techniques that may have been used to motivate professionals to undergo this change?
So from our perspective, in terms of behavior change, I think transitioning onto an electronic platform was really a welcome change in our organization, particularly from the pharmacist perspective. But as in all change management programs and processes, you work with the early adopters first. And so we really try to identify those early adopters, particularly within our pilot hospital selection, so that we could then sort of piggyback off of their enthusiasm and their excitement and their experience with the system for the rest of the rollouts to the other hospitals. I think I think data is the most powerful tool to change behavior, and so the utilization of the electronic system and the implementation of Bluebird really helped us get data on various different levels that help drive behavior change with multiple healthcare workers in that process.
So for me personally, I was one of the end users. So we would do, when we were on the paper system, we were putting in the time, but we weren't seeing the results because a lot of our work efforts were misdirected. So when we started on Bluebird and the system was directing us to see the correct patients, and then we could see that the benefits, it was kind of a great bonus that we could see that the work we were putting in, we were actually getting the results out, which we weren't seeing before we went onto the Bluebird system.
Thank you for that, Angelique and Sonia. Since we are very tight on time, I'd like to invite our audience to send us any other questions via email by writing to lhsn@imperial.ac.uk, and we'll do our best to have your questions answered. Before concluding this event, I'd like to invite our speakers to leave our audience with any additional messages that they may have. Angelique, Daryl, Sonia, please feel free to jump in.
Yes. So to me, I think from the Bluebird system, there's three takeaway messages. The first one is there are big advantages to having a cloud-based system. It's really important that one has an integrated system that includes infection control. So for example, if infection control decide that a patient is isolated as a contaminant, is a colonization, but that patient is on antimicrobials, Bluebird will alert the pharmacist to go and see that patient. And I think that's becoming an increasing problem as we're doing more screening, we're finding more, particularly CRE patients that are colonized, and physicians tend to think those all need to be treated. And then the last point from my side is an intuitive interface that really flattens the learning curve is something that I think we've really graduated to over the last 5 or 6 years.
Thank you.
I think from my side, I really just have one. It's that I think implementation of electronic systems is always challenging, but it's definitely worthwhile in the end. And like all the work we've done previously, it always seems impossible until it's done. And the greatest benefit is that your end users are really impacting on patient care, which is really what you want.
I'll end off. So I agree exactly with what Angelique said. And for me, as one of the end users, it was not having to work harder, but to work smarter. And the electronic system enabled us to do that. And also the relationship building with the multidisciplinary team, when you had access to all this information, is quite remarkable, and it's done wonders for us.
Again, a very special thanks to our speakers for taking the time to share their experiences with us, and a warm thanks to our audience for joining today. If you'd like to learn more about Bluebird, you can do so by visiting the website featured in Dr. Vine's presentation earlier. We're also happy to channel questions over to Dr. Vine via email, so please feel free to write to lhsn@imperial.ac.uk. Again, if you have any additional questions for our other speakers, please feel free to send them over. As a reminder, recordings of this webinar will be available on our website at www.leadinghealthsystemsnetwork.org. As a reminder, LHSN is on social media, so please feel free to follow us on LinkedIn, Twitter, and YouTube, where you can access recordings and new webinar announcements. Prior to ending this session, I'll leave you with an invitation to attend our next webinar on Tuesday, the 27th of November with Dr. Fabiana Lorencato from the Center for Behavioral Change at University City London. Dr. Fabiana Lorencato will provide an overview of ways of applying behavioral science to hospital antimicrobial stewardship programs. To receive reminders about dedicated LHSN events on AMS at the World Innovation Summit for Health, taking place on the 13th and 14th of November, be sure to sign up for the LHSN newsletter. With that, we will close our session. We wish you a lovely day and hope you'll join again on the 27th of November for our next event. Bye-bye.